Then to kick things off, our first speaker is Mr. William Bolton, who is a neurosurgical registrar based in Leeds, and he'll be speaking about extended reality in IR. So I'll hand over to you now. Thanks very much.
Thanks very much, guys. So I hope you can all hear and see my slides. Just shout if you can't. Thank you very much for the kind introduction and for indeed inviting me to present today. Yeah, it's an absolute honor. Congratulations to the organizing team for this event. It looks, it sounds great. I wish I could have attended more. So yeah, I'm a bit of a imposter. I'm not an interventional radiologist or radiologist, but I think in neurosurgery we're one of the few non-radiological specialties that does have to interpret our own images, and we also do work very closely with our IR colleagues. And indeed, some neurosurgeons are dual trained in IR and surgery. So, but anyway, extended reality and the associated technologies are used, or I believe should and could be used for pretty much any medical specialty, but they're particularly useful for all procedural specialties. So when I say IR surgery, I guess, and we're looking at the patient pathway, you have pre, peri, and post intervention. So I consider the applications pretty cross-cutting. Please do feel free to drop me an email or message me on Twitter if you do want to find out anything else or have any questions in the future. Always happy to have a chat with anyone, really. So I've got sort of 15-20 minutes today. So I'm going to sort of give you a high-level overview of an introduction, really, to extended reality, sometimes abbreviated to XR. And sometimes I might use the term immersive technologies. And I think that they're both extended reality and immersive technologies. I think are probably both umbrella terms for the same thing. And I'll go into a little bit more detail about different types of XR shortly. Then we're going to talk about possible future applications within interventional specialties. And then the final slide will look at where I think some of the unmet needs are going to be in the future and where future developments might want to focus on. But you do have a research session in IR after this, so they'll probably go into more detail for that. So I'm kind of assuming that people might not have a huge amount of experience with XR or know some of the terms. So I just thought we'd give a nice overview, really. So essentially, extended reality looks at giving additional information to a user or the person experiencing it, which isn't present in real reality. So in the real world, it's about giving additional information. Normally, that's via simulations, but it could be other sort of visual aids and indeed haptic or sensory feedback and audio feedback as well. So it's about giving the user's brain basically extra information that isn't present in the real world, normally using computers. It's very big in other sectors. It's a huge industry, and it is cross-cutting multiple sectors. But gaming and entertainment and films and stuff has a huge amount of VR. Indeed, quite a lot of people might use VR or other types of XR at home for gaming, but actually getting access to it for training in healthcare is still quite limited. It is good for image-heavy specialties because the extra information you're actually augmenting or adding into real reality is often from image data. And for those of you that have ever seen The Matrix from 1999, epic film, but yeah, so this is basically a story where the whole of human race is in this amazing simulation where they don't even realize they're in a simulated world. They believe they're in the real world. So anyway, it's sort of taken people's imagination, and I guess that's the ultimate kind of logical extension of the development of these technologies. But yeah, so different types of VR. I'll quickly go through some of them. So first of all, which is one of the more common ones, I think, is virtual reality or VR. And even within VR, you can have partially immersive or totally immersive. But essentially, the way to think about it is VR is a whole totally new environment. So you often, put on a headset, which is a screen essentially that's close to your eyes with special optics so that it looks like it's one big sort of room. And when you turn your head around or when you walk around or move around in the environment, it looks and feels like you're in the actual world. So here you can see operating theatres on the left-hand side, which is actual video footage of real human beings and real staff, I assume doing an operation or maybe a simulated operation. And on the right, it's actually all animated with a screen there. But it's basically a totally different environment. Different types of VR headsets. So the one on the left is the Oculus. So that's, kind of a bit more expensive. It comes with hand controllers. I think, in my opinion, you get a pretty good quality experience. The screen's normally really, really good. It's very high res. And the hand controllers means you can manipulate and select things with your hands in space, and indeed practice holding instruments, for example, in interventional procedures. But then you've got all the way on the other end of the spectrum on the right-hand side of the screen. This is like a Google Cardboard. So here it's basically literally made out of, comes flat packed, you make it up, it's cardboard material, folds into the shape required, it comes with the optic lenses here, and you can basically just put your phone in, close it up, put this on your head with a strap, and it turns it into a crude head-mounted display for VR. And it actually works. Very cost-effective way of doing it. I really like that kind of approach because we all have smartphones, even in very austere environments and low middle income countries. Most healthcare professionals actually have smartphones. So I think that's a really good way of reducing barrier to entry. Moving on to a different type of XR. So this is augmented reality. So this is where you do use the real reality around you. So you do use the real patient or the real room, but you overlay additional information. So on the left-hand side, they've got a screen here looking at an operative field, and they've overlaid, I presume, vessels and maybe gallbladder. I think this is the liver. They've overlaid haptic vessels and vasculature, so to help identify, critical structures not to hit, and also critical, maybe that's a tumor, I don't know. Here you've got something called the HoloLens, which is basically in space, in the middle of the room or just in front of you. You've got displayed a three-dimensional image, which you can manipulate and interact with and get a better appreciation of the structure or thing you're looking at. So these are different types. I've just mentioned HoloLens. This is HoloLens. I think this is possibly an engine or something in engineering. So, it's used in lots of different sectors to imagine objects and things, in the design phase of new devices, for example. Indeed, it's used in MedTech actually in the design phase. So will the new device that I'm making actually handle correctly, look right? It's, you can simulate thousands of devices very cheaply, but you can only really invest in making one or two or a smaller number, right? So it's a bit like the same thing in drug development. You might simulate millions of drug molecules before you go down the route. So it's how do we kind of replicate that in devices? But anyway, that's just one example and a kind of a bit of a side note. This is another on the right-hand screen. This is called Magic Leap. Same kind of idea. You put the goggles on, the glasses on, you can see, these guys can see each other in real world, but also see the object. And what's nice about these devices is they're collaborative. So each device knows where the other device is if you're all synced. So, you can see it you can literally walk around it and you can see it from all the different angles. And indeed, you can also have avatars as well. So people can kind of look like they're in the room, but they're not. And a bit like, from films and so on. So other types of XR, so there's another thing called mixed reality, which is basically a bit of a fusion of the two, but you're also interacting with things in the real world. So mixed reality and augmented reality are often interchanged. When you're doing a full, I'll show you a couple of examples of some simulators. When you're doing a full simulation with some kind of screen or overlay, but also hand controllers and devices, I think that's probably mixed reality. So it's about trying to combine as many different sensory inputs, augment as many different sensory inputs as possible. But this is just another way to depict it that I stole off the internet that might be helpful. And then finally, you've got this kind of continuum where you've got, just to help crystallize it in people's minds, you've got the, no device, you might have some smartphone, augmented reality, you might have seen apps where you can get your camera up and look at a statue or something in a museum, and it will then tell you about it, or the statue will start talking to you or something like that, or on a poster, same kind of idea. You've then got sort of, the HoloLens, Magic Leap type classes, and then you've got full VR, which is where you're taken totally away into a new immersive environment. So haptics, another adjunct. So haptics is another term that some people might use. Haptics is something that provides sensory information. So for those of you that have a smartphone, when you press the buttons on the screen of your smartphone, you're not actually depressing any buttons. It's just a flat screen, but it buzzes and makes it feel like a button. That's kind of an example of a haptic that we might use in everyday life. But yeah, you can have, as you can see here, you can have kind of almost exoskeleton type haptics. So here, this person has things on their fingertips attached to their wrists. So when they actually reach for the object in non-reality, in virtual reality or augmented reality, when you close your hands around it, the computer will actually provide resistance, and your hand will actually feel like you're trying to, you're actually grabbing something. And you can actually reverse the equations. And actually, for people who have paralysis, you can actually, reverse it and actually move the hand and stuff. So anyway, but that's really cool. So haptics and the kind of convergence of technologies, with the physical adjuncts and the virtual world is quite big at the moment, and certainly an area of active research. And then on the right-hand side of the screen, you can go even further. So this is a 360-degree treadmill, so they can move. They're sort of strapped in at the waist, and they can kind of move. They can like run in like, they won't actually move. They're physically in reality stationary, but they'll feel like they're moving through a virtual world, which is super awesome. A bit like Ready Player One, if anyone's seen that film. Just some examples for surgery, I guess, interventional procedures. This is I think a knee replacement example here. So they've got a fully immersive headset on here. They've actually got also audio as well, so it can like fully block out other sensory input to make you feel more, I don't know, immersed and involved. And then you've got the actual handheld instruments here, which will provide resistance that matches what you're actually seeing in the virtual reality. And then here you've got a laparoscopic simulator, so for minimally invasive surgery. But you'll put a headset on so that when you look around, you don't see the brick wall, you actually see the theatre. So that might be good for non-technical skills and situational awareness training and so on and so forth. But then the haptic box, the device here, actually provides the mechanical feeling. So I just thought I'd move on to talk about, and maybe it's a bit of a conversation that's ongoing. And again, these are some of my opinions, I guess, rather than necessarily what we should do. But I think I like to think of it about how XR could interact with the patient along the whole pathway. So from operator training, interventionist training, before they ever get their hands on the patient, all the way through actually patient consent and education, pre-procedure, any planning and practice runs. I've got one of my consultants in neurosurgery says that pretty much at the end of every operation, he always turns to me and says, if we went back in time and did that exact same procedure again, we would definitely do it better every single time. And when he first said it to me, it kind of I was a bit like, oh, that's, I don't know, it resonated with me, because I was like, oh, you're right, that's really interesting. So why is the first time that we do something on a patient, why can't we do practice runs and try and simulate it? And with images, we can get patient specific data, can't we? So if we practicing on the actual images that we're going to be using, isn't that awesome? You can actually literally, in our case, clip an aneurysm 30 times before you do it for real, or whatever it is. Then you've also got intra-procedure navigation and maybe scrubbing in virtual assistants, and then the post-procedure recovery and rehabilitation. So how can XR interact with all these different things? So this is just a cheeky plug for a study that we did in Sierra Leone. So this was looking at breaking down barriers to access for these technologies for developing countries. So we collaborated with the University of Sierra Leone, which is in West Africa, one of the lowest income countries in the world, with no postgraduate surgical training. And we did a randomized control trial, feasibility study, so it wasn't powered. But basically, we were looking at, can VR supplement hands-on courses that they're reliant on? So they don't have postgraduate training, they're reliant on international people coming in, doing a quick course and going. But can VR sort of modules take away like the pre-learning and improve the kind of skill acquisition on the actual course? And basically, although it wasn't a power study, the trends did suggest that it would. But this was really looking at, is it possible to use this kind of what's considered quite high-tech in a very austere environment? And the answer is yes, yes, we can. And the trainees were really great. They took to it, really, really, really well, which was really promising. So we're now looking at introducing this before neurosurgical training courses and boot camps as pilots. And if that goes well, it might be the case for many courses that we have to go on. You will get, pre, during, and post course access to modules, but in VR, which I think for procedural training, the immersive element is the experiential element is really important. Then you've got patient consent and education. I just put a couple of what I consider to be quite good references here. And this is a company actually providing the service. So this is looking at, when we're consenting a patient for a procedure, how much are they really understanding? And when you look at what consent should actually be, it's about the expert professional and the non-expert professional coming together on exactly the same page. How do you actually bring them to the same level? And you might see it in clinic, your boss is drawing out some anatomy and here's the aneurysm. That's fine, and everyone does their best, and it is satisfactory. But can we make it even better and use immersive technologies to actually show them what we're going to do, and maybe make them more informed have a better understanding of their condition. And indeed, this RCT showed some positive results, which is great in terms of building relationships and supporting informed consent, which I thought was really interesting. So now pre-procedure planning and practice runs. Another plug, one of my colleagues in Leeds, he's a general surgeon. He basically did a huge study looking at many procedures, hundreds of thousands, basically showed that if you do the same type of procedure, so not the same procedure on the same patient, obviously, but if you did like lots of lap choles all in once, but your last lap chole was much shorter, had much less complications than your first one on average, despite correcting for multiple confounders. So basically it showed that practicing warm up preoperatively improves outcomes and so on for patients. So it's like, you know, an athlete would warm up before a race. They wouldn't just go straight in. They'd do some dry runs. They'd warm up and go. So this is on the right hand side. This is a neurosurgeon doing some preoperative planning on a tumor case, and they're visualizing the anatomy and the relationship with the critical structures, so that when they actually get in there, they know, you know, how much bone do I have to take off, or how deep do I have to go, or whatever, or, you know, what's the relationship to that structure, how safe am I there. And you know, most interventionists would go through it kind of anyway in their head. They'd look at the scans, they might sit there the night before figuring it out. So we kind of do this anyway, but it's how do we provide extra information and maybe make that even more efficient with XR? I'm just conscious of the time. So intra-procedure navigation. So this is kind of the really, what I consider quite exciting part. Again, lots of neurosurgical examples, I'm afraid, but I think, you know, it's relevant. So here we've got the scanning, so we do some imaging, we get the images, and then we do the intraoperative registration, and then this provides the navigation. And the same can be true for any table, you know, for any intervention in theory. And this is someone doing some preoperative planning here with the HoloLens. Just another example here. So this is the kind of real world, the virtual image, and then the superimposed in AR. So this is looking at flow through vessels. And here is a tumor. We've got a surgical view. This is the tumor. It's quite difficult to sort of discern. Got the uncorrected AR view, so doesn't really matter, but basically the preoperative image, even if you do them the day before, they're going to be a little bit out of date, especially when you remove other structures, things move, so you can then correct it with intraoperative ultrasound. And this is just another example of helping identify critical structures and targets. People might have heard of Proximy. So this is an augmented reality and telepresence company that provide a service here. So here you've got surgeon in country X or place X, unit X, doing a cleft lip, and here you've got a expert somewhere else and giving virtual remote assistance. And this is that person's hand in this person's space. If that kind of makes sense. So you know, he's drawing, he's showing where he'd make the cuts and stuff. So you've got a consultant virtually scrubbed in with you, or extra assistance, which might be really important for complex procedures, or if you're training people far away, or indeed in global health contexts. This is just an augmented reality, an interventional radiology example that I managed to Google, essentially, to be honest with you. Here, I thought it was quite cool. They've got like QR code registration stickers, markers on here, over some bony landmarks, I assume, or some ribs, so that you can reference to the actual images. And then you've got a handheld device so you can plan your procedure. And just some thoughts, really. I'm not, like I said, you know, you guys will be potentially experts in this versus me, definitely. You know, tumor ablation, biopsy guidance, and then just, you know, even if there's a better appreciation of vascular anatomy and critical 3D anatomy, you know, even if it makes you feel more confident, you know, about your understanding, I think that, you know, it is the challenge really is unpicking it in terms of evidence generation. But you know, I personally feel that it makes me perform better if I've got a better 3D understanding of this. And then right after the operational procedure, about rehabilitation. So you could put a headset on someone. You know, we have our physiotherapists doing this, where they sort of you know, work with a patient to actually do the exercises, you know, actually engage with it rather than reaching for, you know, real cups or whatever. And they can do this even, you know, for you know, a kind of digitally literate patient or a young patient. Lots of our patients are quite young. They can do this even when the physio is not there, and they get out of hospital quicker, which is great. Here, you know, even like we've got sort of controlling different limbs and so on, for example, and rehabilitation after major injury. This is just a picture of a calming scene. Anyway, I found this because some researchers were looking at the use of this in stressful environments like intensive care. And giving a calming scene, relaxing scene can help with anxiety and the need for anxiolytics and analgesics and for pain control. So anyway, so it's got a huge range of potential applications, I believe. Coming on to my last slide now. So looking at the future, I think, there's a lot of places that this could go. I do believe that, quite a lot of people are cynical, oh, we can't even get the printer to work on my ward, which is true. The NHS is not digitally ready in a lot of ways, but I think it's going to take sort of early adopters and innovators, like I hope a lot of you guys will become, to actually champion this technology and sort of advocate for it. So I think there'll be a convergence of XR with other technologies. So like I said, the haptic simulators, maybe even 3D printing. So wouldn't it be cool if you could make a 3D printed patient-specific model, overlay extra information, maybe simulate complications like bleeding or whatever, and you actually do the whole operation and you change it up. Someone could throw in a complication here and there, or the anatomy slightly shifted because of the position of the patient or something like that. I don't know. But how can we best be prepared so that when we do the intervention for the real patient, we're as prepared as possible? I think that's, for me, what's most exciting, or one of the most exciting things. Breaking down barriers to access. I mentioned this integration with digital health systems is going to be a challenge, but we'll get there. It needs to be clinically, in my opinion, I think it will be helped by having clinical champions, being clinically driven, clinically led. Because if consultants start saying that this is what we need to do, then things will start happening, I believe. But indeed, trainees and students, we're going to be the consultants sooner than you realize. So it's certainly up to us as well. We need to generate the educational evidence and the clinical efficacy evidence, which is difficult, but there are some cool potential methodologies here and assessment tools. We also need to demonstrate the health economics, and I believe there's a huge health economics argument. If you think how much more efficient we are now that we're using computers and phones versus written messages, I think it's the next evolution, in my opinion. So I'm going to stop there. As I said, there's my contact details on the screen. And I just want to say thank you very much for inviting me to speak. And I don't know if we have time for questions, but I am happy to stay around for a bit if so. Otherwise, hope you have a lovely rest of the day, guys.
Thanks very much, Mr. Bolton. I thought it was a brilliant talk with lots of really important insights into how these technologies can be implemented into current procedural practice, and particularly in improving the patient experience. And of course, for clearing up all the really confusing terminology used to describe XR. We've got time for 1 to 2 questions. So if anyone has any, just feel free to pop them in the chat or unmute yourselves.
I'll ask Will a question, if that's okay. Which of all the different ones you mentioned, all the technologies, which one do you think is going to be the most useful for surgical and interventional trainees in the next sort of 5 years or so?
Yeah, I think it's a good question. I think it's difficult because we do have a range of choices, and I think I'm going to end up sitting on the fence because I think it's about the right tool for the right job, and each of them have a slightly different strength and associated weakness. I think the ones I feel like I get the most out of myself is probably the augmented reality stuff. So in theatre now we have Magic Leap, which is an AR setup, and that's just great. We already use neuronavigation for most elective work, and so just to be able to put a headset on, overlay it, like without having to like constantly look at the screen or whatever, like even that just makes a huge amount of difference. You can also combine it with other things like microscopes and other image acquisition devices. So for me, I think it's that. And you can also, with the combination of, models or the real patient, you can also simulate it and practice it in your head. But yeah, I do think I'm going to sit on the fence and say that they're all probably going to be quite useful.
Yeah, because I know you showed Prof. Solbiati's groups that they're sort of overlaid 3D images on like a phantom, or obviously you can implement that on a real patient as well. And now there's lots of, in the ablation world, like CT navigation. It almost feels whichever one you get trained on, you sort of already are biased towards favoring that because there's always a learning curve, isn't there? Yeah. But perhaps in the future, once there's more robust, validated technology, then you can directly compare those. But it's so cool, all the things you've shown and the stuff that you're using in neurosurgery clinically now. It's quite amazing. Yeah.
No, it's great. We're really lucky. We've got very sort of early adopter and innovative consultants, which is really helpful. I think that's critical, actually.
Thanks so much, Will. Great talk.
Thank you very much.
Just got one more question, if that's fine. Oh. So it's great talk. Thank you. What is the learning curve with using these technologies?
It's a really good question. And I think it's important with any new device. So when minimally invasive surgery, for example, in our world was introduced, laparoscopic, learning curve definition was really, really hot topic, really, really important. And now it's about transitioning to robotics and other types of minimally invasive stuff. So I think it's really, really important. The short answer is I don't know that the learning curve has been defined. I think in terms of the learning curve of putting on a headset, knowing how to switch on the software, access the system, access the images, register and stuff, it's probably only a few cases actually, or a few goes actually. It's probably a small number. I think actually using it in the procedure is different, and I don't know for sure. But I think that will be important. I don't expect it will be that difficult though, particularly if you've already done it non-clinically. So anyway, but yeah, I don't really have a good answer.
So if there are no more questions, we'll move on to the next talk. Thanks again, Mr. Bolton.
Bye.
So our next talk will be on IR research